all very much for joining us today for this first OncoAlert Tumor Boards. Today, we are discussing a great case in non-small cell lung cancer, and our expert faculty will guide us not only in the presentation of the case, but giving us specific insights in the medical, surgical, radiation oncology aspects, and even in the role of liquid biopsies. So we are joined today by I will say, magnificent OncoAlert lung cancer faculty, Dr. Naidoo, a thoracic oncologist focused on immunotherapy for lung cancer and immune toxicity from Beaumont RCSI Cancer Center in Dublin, adjunct assistant professor at Johns Hopkins University, Dr. Jack West, clinical executive director for Access Hope, and medical oncologist at City of Hope, founder and president of Cancer Grace. Dr. Stiles, professor and chief of thoracic surgery and surgical oncology at the Department of Cardiothoracic and Vascular Surgery at Montefiore. Dr. Willers, director of thoracic radiation oncology and radiation biology programs at Massachusetts General Hospital. Dr. Rolfo, associate director, clinical research at the Center for Thoracic Oncology, Tisch Cancer Center, and the president of the International Society of Liquid Biopsies. Our moderators are Dr. O'Kane, medical oncologist from Ireland and translational researcher in pancreatic and hepatobiliary cancers, and Dr. Westphalen, physician scientist from Germany and translational researcher in pancreatic cancer. I am your host, Gil Morgan, clinical oncologist from Texas, practicing in southern Sweden, and director of the OncoAlert Network. The format today will start with Dr. Naidoo presenting the case, Dr. West taking us through the medical oncology aspect, Dr. Stiles in the surgical oncology aspect, Dr. Willers through the radiation oncology aspect, and finishing off with Dr. Rolfo in the role of liquid biopsies. We will then be taking questions that are posting on Twitter, and please be sure to follow the conversation as we will be live tweeting in real time, and follow the hashtag OncoAlertRT, OncoAlertRT. So now, without further ado, Dr. Naidoo.
Thanks, everyone. A pleasure to kick off the OncoAlert Tumor Boards with non-small cell lung cancer. So our first case is a nicely controversial case of stage 3A disease. So this is a 42-year-old female never smoker who presents to the emergency room with sudden onset chest pain and is found to have a 4.2 centimeter left-sided lung mass and enlarged mediastinal lymph nodes on staging PET-CT with no disease on brain MRI. Bronchoscopy and endobronchial ultrasound reveals adenocarcinoma cells in the lymph nodes at level 4L, while level 5 could not be reached. And these cells have a PD-L1 score of 5%. The patient's cancer is therefore staged as a CT2B-N2, stage 3A non-small cell lung cancer, and a thoracic surgeon deems the tumor to be surgically resectable. Our questions are, firstly, what is A, the next step, and B, the optimal treatment option? Is it 1A, full NGS testing, followed by B, neoadjuvant chemoimmunotherapy followed by surgery? Is it 2A, full NGS testing, followed by definitive chemoradiation, and then consolidation durvalumab? Is it 3, EGFR testing alone, followed by definitive chemoradiation, and then consolidation durvalumab? Or is it 4, and this is somewhat controversial for an N2 case, may more apply to a N0, N1, but nevertheless, EGFR testing followed by primary surgery and then adjuvant chemotherapy, followed by atezolizumab if EGFR wild type. Taking us through the landscape of clinical trials that may inform some of our decision-making. And of course, we've seen the publication of several of these trials just in the last couple of weeks. So many of us are sifting through this data and trying to find how we think about this. So the first is, of course, the neoadjuvant chemo IO studies heralded by Patrick Ford's Checkmate 816, just published yesterday or the other day in the New England Journal of Medicine. And just to recap, in this study, patients with 1B to 3A non-small cell lung cancer were randomized to either 3 doses of nivolumab with chemotherapy versus 3 doses of chemotherapy alone, followed by surgery with or without adjuvant chemo with or without adjuvant radiation. And this study demonstrated an event-free survival benefit with a hazard ratio of 0.63. And importantly, 64% of patients in this study had stage 3 disease, and there were lower pneumonectomy rates in patients who had been treated with chemoimmunotherapy as opposed to chemotherapy. Moving on to the data in the adjuvant setting, so in patients who have primary surgery, we have seen data from Empower 10 and more recently the Pearl study, exploring the use of adjuvant immunotherapy. In the case of Empower 10, after platinum doublet chemotherapy, patients were randomized to 16 cycles of atezolizumab versus best supportive care. And this identified a disease-free survival benefit, hazard ratio of 0.66 in the PD-L1 greater than 1% population, and 0.79 in all comers 2 to 3A disease. And then lastly, of course, the Pacific study, the most mature study, now with 5-year data, 5-year overall survival data with a hazard ratio of 0.72, 5-year progression-free survival data with a hazard ratio of 0.55. And to recap, in this study, patients had unresectable stage 3 non-small cell lung cancer, were treated with definitive chemoradiation, and received 1 year of durvalumab compared with placebo. Controversially, of course, we have a couple of different speakers today representing Europe and the US. In the FDA, this is approved regardless of PD-L1 status, while in Europe, this is approved in the PD-L1 greater than 1% population. And of course, the benefit in the EGFR mutant subset, controversial, with a wide confidence interval and a hazard ratio of 0.76, but a confidence interval that crosses 1. So really unknown in that space. So moving on, there are a number of open questions in the stage 3A setting, which I think this discussion will inform. Firstly, should we consider resection in stage 3A non-small cell lung cancer? Of course, Checkmate 816 and Empower 10 would suggest yes. There were no patients who underwent resection in Pacific. They had definitive chemo rads. Of course, when is the best time to resect? Checkmate 816 and Nadim before it would suggest post-chemo IO. Empower 10 would suggest upfront. Does PD-L1 status matter in the early stage setting? And if so, what is the optimum cutoff? In Checkmate 816, we saw a benefit across all subsets. In Empower 10, in the PD-L1 greater than 1%, Pearls, of course, more controversial, difficult to tease out in terms of subsets, and Pacific differences in US and European approvals based on PD-L1. How should we assess the benefit in patients from IO or chemo IO in stage 3 non-small cell lung cancer? What's the optimum endpoint? In the neoadjuvant setting, do we defer to PathCR, major pathologic response, or event-free survival? In the adjuvant setting, disease-free survival, and of course, the gold standard of overall survival that we have seen with Pacific. Of course, the oncogene-addicted subsets, what should we do for EGFR mutant stage 3 non-small cell lung cancer? Obviously, these subsets included to some degree in some of these studies, but not powered to tell us how we should proceed. And then extrapolating that, what should we do for other oncogene-addicted subsets for which there may or may not be a benefit for immunotherapy? How does chemoimmunotherapy count for this? And of course, what do we do in the meantime while sifting through all this data? So with that, I think I'll hand over to Jack to help unpack that for us.
Oh, great. Now we've solved all of this. I'm very happy to be here, and I think this is a very thought-provoking, really provocative case without a clear best answer, and that's why there's so much room for debate. It's kind of refreshing to be at such a crossroads with so many appropriate options and just a big array of pros and cons to many of these. With regard to the one of the first questions that Narushka mentioned, which is really what degree of testing could or should be done. Certainly with EGFR as a clinically relevant marker, the one that has the most established role, I would say that makes sense to test for at a minimum, and that includes in the preoperative setting before committing to chemoimmunotherapy, if that was the approach to pursue. There's the argument for NGS. And in this case, I would be inclined to do it. Now, my general feeling is not necessarily to do far broader testing than is clearly indicated. But in a never smoker, the pretest probability is high enough, especially in a younger never smoker, that I think that it would be worth knowing if someone has an ALK rearrangement, ROS1, RET, MET, etc. We don't have a clear answer exactly to how to treat with that, in terms of, we don't have an Adora for ALK or others, but the differential utility of immunotherapy in this population, I think, makes it worth knowing. So that's my approach. I would be inclined to favor a broader testing, particularly in a population with a high pretest probability. I think one of the big questions in this setting is also the timeliness of potentially starting chemoimmunotherapy. And Dr. Adeo, not in this panel, but participating in many thought-provoking discussions online, also raised the point of, well, we could always start a cycle of chemotherapy while waiting for NGS to come back and then add the nivolumab. It would not be excessive to give one cycle of chemo before you get the NGS panel back, and then give the next 3 cycles with nivolumab. That would not be excessive treatment at all, just coming out to 4 cycles of chemo and 3 of them with nivolumab. So I think I'll leave that question there. I think another important question, of course, is whether we favor a surgical or a non-surgical approach if someone has multi-station and 2 disease. I think this is really going to depend on judgment, patient wishes, and the skill set, experience of the surgeon. The fact that if it would not require a pneumonectomy, it would be something that is important to me. If something is potentially considered resectable but would entail a pneumonectomy, I would be more inclined to favor pursuing a non-surgical approach for such a patient. And then there's the question of, if it is surgical, would you do preoperative or postoperative? I have come up with a few thoughts on my preference for neoadjuvant, which I think is for several reasons. One is it's a shorter course of treatment that if you're doing 3 or 4 cycles, compared to the option of a year of adjuvant immunotherapy, that's tacked on to the chemo approach. And that includes more toxicity, more of a chance of people stopping treatment, and more cost. So I'm impressed that the results that we've seen achieved that seem so comparable between Checkmate 816 and Empower 010, or arguably Pearls, are with different durations of treatment. And I would also emphasize that far more patients are actually able to get the intended treatment if it's administered preoperatively than postoperatively. I think this is something that is really minimized or not appreciated enough. Dr. Philippe and colleagues 10 years ago, more than 10 years ago, published the NATCH trial that looked at carbopaclitaxel given preoperatively or postoperatively versus surgery alone. And there were no clear differences between the preoperative and postoperative approach, but also trends were better for preoperative, and more than 90% of the patients were able to complete the preoperative treatment versus only about 2/3 even starting it, and only about 60% getting through the intended treatment. This was not as intensive as cisplatin-based chemo and a year of immunotherapy. This was just 4 cycles of carbopaclitaxel. So there's a real risk of attrition and somewhat of an issue with front door and back door that I think we need to recognize, that you cannot count on people getting postoperative treatment as planned. And the third issue that I think is really valuable is that we've learned our breast colleagues have been able to move a lot of the treatment to the neoadjuvant setting and use that to inform their treatments that follow. based on whether someone achieves a good imaging and pathologic complete response, perhaps. We did see from Checkmate 816 that path-CR was very predictive of later outcomes, and it would be valuable to use this information rather than just treating patients blind in the postoperative setting. One final comment I'd have is that I am very impressed by the Pacific trial and think that's really strong data, more than 10% improvement in 5-year overall survival and PFS. So I think we can really think that we are changing the cure rate in the setting, but it's an apples to oranges comparison when the people who went on Pacific were had already gotten through chemo and radiation without progressing and without a drop off in their performance status. You lose about a quarter to a third of patients before they get to that point. So this is a siphoned off population destined to already do better. And it's not quite fair to use these numbers to compare, but these are all good options. I know there's a lot to cover here, so I'd like to end here and turn it over to Brendon and others to cover the other nuances.
Well, thanks, Jack. It's, as always, the two of you are tough to follow. There's a lot to unpack there and a lot to think about. I think, I'll sort of just take this case from the surgeon's perspective and talk about some of the things that we think about and that hopefully others think about it. I think Jack made a couple of really good points about surgical expertise, number one, and about patient wishes, number two. There is no textbook for these cases, stage 3. I think they can go a lot of different ways. I think it depends a lot upon the local expertise at the institution. I think it depends a lot upon which road the patient wants to go down. When surgeons are thinking about these, one should really ask, not can we do surgery, because we always can, but should we do surgery? And that the classic things that people talk about and surgeons talk about is single station versus multi-station, bulky nodes, extracapsular nodes. But often I think for me, it comes down to extent of resection. I feel like I and many other great surgeons, or I'm not saying I'm a great surgeon, but many great surgeons can resect bulky end-to disease. Extracapsular spread is a little bit different thing, and certainly surgeons can resect multi-station end-to disease. But the question is, can we do that without a pneumonectomy, as Jack said? And pneumonectomy is not the end-all, be-all, but it certainly slows patients down. It's been described as a disease unto itself. And we know that is a difficult physiologic state to put a patient in. And so I often think of that as a break point for when I want to have a serious discussion with the patient about really, should we do this? With regard to that, one of the inspiring things I think from Checkmate 816 was that in the stage 3 patients in particularly, I think surprisingly to a lot of people, it showed that there was a decrease in the rate of pneumonectomies from 30% to 17% with the addition of nivolumab. That's pretty remarkable to me. I was never really a huge believer of this idea of downstaging disease or being able to change a patient who needed a pneumonectomy to a lobectomy. But that data certainly is suggestive of that and speaks to that. Anecdotally, I had that with one patient on a trial that we did at Cornell where I was sure was going to need a pneumonectomy and I was able to do a lobectomy. So maybe there's something to that. I think we have to be careful, though, not to dive all in, though, and start to think that we can convert every pneumonectomy into lobectomy. That's certainly a concern. This case presents some interesting challenge in that it's left-sided 4L disease, which is sometimes a challenge for surgeons. And I think this, every case is really individualized, but bulky paratracheal disease from the left is much harder to get out because the aorta is in the way. It's up high there in a difficult space to obtain. And I'm interested to hear from surgeons on Twitter how they approach that. Some might say do a mediastinoscopy first to clean that out, even at the time of resection and things, but it can be challenging technically. I think, the other thing then that comes into play here is neoadjuvant versus adjuvant. And Jack mentioned the NATCH trial, which I think shows a really important point about 90% of patients getting full therapy versus 60%. That trial is often taken to mean that there is no difference between neoadjuvant and adjuvant in outcomes. But I think one must remember that about half of the patients in that trial were pathologic stage 1, who wouldn't really expect to get much of a benefit from adjuvant therapy or neoadjuvant therapy. As we get better and better adjuvant therapies, atezo, OC, as we get better neoadjuvant therapies, we know that the delivery of therapy is going to be a critical predictor in how patients do. And that, to me, is just much better done in the neoadjuvant space before we've put the insult of surgery on patients. And the data, I think, holds up to that. And in recent studies, the Violet trial was a surgical trial that showed that just over 50% of patients were able to receive adjuvant therapy. There was a great update from the Alchemist trial that showed that, very low rates of completion of adjuvant therapy. So I think despite many, many advances in surgery, minimally invasive techniques, we still have a tough time getting them all to adjuvant therapy. I think that will change as there's more enthusiasm for adjuvant therapy, but it will be interesting to see how this goes. For this patient, regarding molecular testing, I certainly would try to rule out EGFR. That might impact whether I put them on the Checkmate 816 regimen. But I think if resectable via lobectomy, I'm a believer in the neoadjuvant strategy. And I think that it's, in patients like this with somewhat bulky disease, it makes a lot of sense. And I'll stop there and let others comment. I hope that we'll come back and talk about some of these nuances as we go. I think this patient, just for the record, could be treated with chemotherapy and radiation as well with the bulky disease. And I wouldn't sort of quibble with that for a lot of places. So lots of good things to talk about. I just saw it flashed on Twitter as the slide about the advantages of neoadjuvant therapy. And I stole a lot of those comments from an article that Jamie Chaff did, who's really thought about this a lot. But I do think there's a benefit from having an in situ tumor as well for immunotherapy in particular. So I like that option for this patient.
All right. I have a very tough act here following Jack West and Brendon Stiles, but I'll make the best of the 5 minutes that I have while Gil is sending out the 5 slides that I prepared. So as a radiation oncologist at a multidisciplinary tumor board, for a case like this, it's not easy, as you can imagine. So the things that go through my head, and some of this is a bit repetitive, so forgive me, but as a radiation oncologist, we do want to know whether stage 3A clinically and 2 is histologically confirmed. And that can be sometimes challenging. Brendon alluded to that, low 4L sometimes is difficult to reach, even with the mediastinoscopy or EBUS. Level 5 is very difficult. It may require a Chamberlain or even Barrett's procedure. And I do want to know whether N3 disease has been ruled out. Certainly, I do want to know EGFR status, and I think PD-L1 score, I will want to hear what that is, because it if not now, but then in the near future, it will affect decision-making. And I want to know whether a patient is medically operable and the disease resectable in a reasonable way. I mean, you can resect bulky disease, but should you? Does that biologically make sense? Because it may not just be a difficult resection, but also a marker of bad disease. And I think a pneumonectomy, practicing at Mass General with several excellent, all of them excellent surgeons actually, I think pneumonectomy would not be an argument against, but you may not know about it before. And then I'd say in deciding between surgery and radiation, the decision needs to be made upfront. It needs to be made with a surgeon. It should be made with invasive staging so we know what the nodal disease is. I don't think it's a good idea to start 60 gray with chemo and then send the patient to the surgeon and let them figure out whether it's still time to the surgery. And then last but not least, very true, on my first slide, always listen to your thoracic surgeon and medical oncologist, and you can never go wrong. As Brendon alluded, that's the second slide, Gil, is that there are many options available, and we really don't know which one is the right one for somebody with N2 disease, because we really have we have limited level 1 evidence, especially comparing neoadjuvant chemo-nivo versus definitive chemoradiation. And on the slide, I also threw out there, and you forgive me, I had to do that, neoadjuvant chemoradiation maybe was temporarily dead, but it may not be as we learn more about the subsets in the Checkmate 816 trial that may or may not benefit. So we haven't really, in that regard, with level 1 evidence, progressed not very much since the intergroup 0139 times. I have that on slide 3, where you could make an argument based on a post-hoc analysis that trimodality therapy with surgery is the better option than chemoradiation. Certainly the Checkmate 816 results look much better, but they do include stage 1B and stage 2. And recently published is an exploratory analysis of the Pacific data specifically for the N2 subgroup. And at least the early outcomes in both in terms of OS and PFS, they look actually pretty good. Obviously, and I'm glad that Jack already brought up the apples versus oranges comparison. That's what we all do. The N2 group in Pacific is certainly not the same N2 group. That is the surgical subgroup in Checkmate 816, and obviously intergroup 0139 without PET staging. Who knows what's in that population? So again, patients have really multiple options, and the pros and cons need to be weighed. With regard to radiation specifically, Gil, this is slide 4. I think we definitely would be quite happy to offer definitive chemo radiation followed by durval if a patient is deemed inoperable, unresectable, or if a patient needs an immunectomy and there is not sufficient thoracic surgical expertise available to support that. In terms of postoperative radiation therapy, now that's very unclear right now, both for incidental stage 3A, where it's pretty much dead, but also if you still have residual disease after treating gross 3A and 2 with a neoadjuvant chemo-nivo. I think we need more data there. We need a patterns of failure analysis to learn whether adjuvant radiation makes or does not make a difference. And so neoadjuvant chemoradiation, it's always been an institutional preference. Many institutions preferred prior to Checkmate 816, preferred neoadjuvant chemo. At MGH, we always preferred neoadjuvant chemoradiation, and that may still be an option in the future for some. You could argue that the benefit in Checkmate 816 was driven by the high PD-L1 expressors. So maybe if you have your low PD-L1 expressors, maybe some other markers, that may still be an option. Radiation combined with chemo is very good at sterilizing mediastinal lymph node stations with good outcomes. At MGH, the median survival time with this kind of approach is 49 months, which is quite solid. And so on the last slide, I reminisced a little bit about, the past CR question. You can look at it on Twitter. Maybe I'll just save that here to not get bogged down in details. But I think in the end, what we will end up is that we will get away from these one-size-fits-all approaches. There will be lots of subsets in the group of people who have stage 3A disease, and the treatment approach will be individualized. For this case before, so young non-smoker, or never smoker rather, fit with EGFR wild type and PD-L1 5%. I'd love to hear from Brendon and Jack in the discussion how they would approach it. I think I would actually favor a chemo radiation approach, because it's really not quite clear whether this patient would benefit from induction immunotherapy, but that should be an important discussion. And then last but not least, if I may, whatever the tumor board decides, it is still a decision between me and my patient. We kind of need to sit down together and weigh a patient's view on things. It's not just about PFS and OS. There are other things that sometimes go into decision making. And with that, I'll yield my slot to the next speaker.
Thank you very much for the great summary that you was doing. And actually, one of the questions that Dr. Naidoo put there in some of the slides is, how should we assess the benefit to patients to IO, chemo, or IO in stage 3? And here, liquid biopsy could be a good answer for that, including also the possibility to test in a next generation sequencing all the targets, not only EGFR. We know that we have actually several trials going on in this scenario with targeted therapies. But going to patients that have resected disease, we have some of the approach that liquid biopsy can be working with tumor-informed or tumor-uninformed approach. And in case of both of these technologies or this approach, we have the opportunity to get, in patients that are resected, the opportunity to get the relapse detection. Some of these approaches that I want to focus, the first one is the TracerX, that is the creation of this phylogenetic approach that is very personalized, departing from tissue, creating for multi-sample regions and exon sequencings of these regions, and creating these phylogenetic trees with the information of clonal and subclonal single nuclear variants, and from there going to create pools for liquid biopsy, extracting the ctDNA, and through the PCR next generation sequencing, have this again phylogenetic tracking for pre-surgery and in relapse. And this study that was starting by the group of Charles Swanton in 2017, we have nowadays an important results coming with a good specificity and sensitivity. And even though it's a very personalized, it's really interesting to get the data. We can even discuss patients that are having a recurrence on the ctDNA during the chemoradiation or during the chemotherapy, actually in the neoadjuvant. And that could be also interesting to detect that patients that are relapsing or resistance during the radiation or the chemotherapy. Another approach is also the CAP-seq that is analyzing the liquid biopsy. It's not tumor-informed, it's only using liquid biopsy. And there, in some of the studies that we have, for example, the study published in Cancer Discovery in 2017, we have there data coming from chemoradiation and patients. In this case, I think it's a very interesting tool, liquid biopsy, especially when we are doing chemoradiation and we have after some equivocal situations like persistence of disease versus pneumonitis. And in this case, the liquid biopsy is able to see if the patient is incomplete, non-detectable at the moment of the chemoradiation, and continue like that and see if that is related to a fibrosis. Finally, there is an important comment that here we can do, that is the consolidation. When we are doing consolidation, we don't know how to really select these patients for consolidation, but liquid biopsy here can also give us an opportunity, and Maximilian Dean did a very interesting retrospective analysis in 2020 that is actually taking in consideration the patients that are going for immunotherapy in consolidation. And here, patients who have non-detectable disease or non-detectable ctDNA were having a better progression-free survival, but also in patients that have a complete non-detectable ctDNA situation after chemoradiation. Some of them, for example, one of an anecdotal case that he presented there, have no progression but have a grade 5 pneumonitis. So the idea that we can select patients that are not really going to be beneficial with immunotherapy, but getting more toxicities, is also an interesting point to consider. And we will need, obviously, clinical trials answering these questions and selecting these patients. Finally, the Empower 010, they presented data on the subgroup of stage 2 and 3 with ctDNA, and patients have detectable ctDNA after the treatment, they have a worse outcome. So I think it's still ongoing, the research. We will have a lot of opportunity to see trials, including the MERMAID trials and others. But we will have a lot of opportunities to apply liquid biopsy in this scenario. There are dynamics of ctDNA that are already applied in some of the cases. And this is a scenario that will be very interesting for research, not only in liquid biopsy, but tumor-informed approach as well. So I send to you, Gil, for the wrap-up.
Thank you very much, Dr. Rolfo. Everybody, it was amazing. I really, not only was it a spectacular case, but just to be able to sit here and be completely starstruck by the not only the great commentary, but the source of the commentary. So thank you all very much for being present or for that wonderful discussion. Now we will move on to if there are any questions from the Twitter sphere. We have our moderators who are have been taking up the questions. And first, we will start off if there are any questions from the faculty to the faculty.
Yeah, actually, we have a lot of them. This is Ben Westphalen speaking. So we have talked a lot about different modalities and how to combine them in the neoadjuvant setting. And the first question goes to Brendon. Brendon, do you see a potential role for radiotherapy in the neoadjuvant setting together with chemo and immune checkpoint blockade, so further intensifying preoperative treatment?
It's a great question. My groups that I've been with institutionally have avoided neoadjuvant radiation for the most part, full dose radiation. I think in that setting, I'd rather sort of save radiation for residual disease. You'll probably know that the trial that we did at Cornell, really led by Nasser Al-Turki and Sylvia Fremente, we added low dose radiation to single agent durvalumab. And of course, we saw a higher rate of pathologic response, which you could expect by adding local therapy. But it was really a non-ablative dose, 8 Gray times 3, and we really saw a signature of immune priming there. And so I do think that there's probably something to that, as others can tell you better than I. Pacific sort of hinted at that arguably as well. I think the field's wide open. I think we should explore other combinations. I think the real question with Checkmate 816, the preliminary survival curves on the complete pathologic responders are just startlingly amazing. And the question there is, does complete path response after radiation added those other things, is that the same as just after chemoimmunotherapy? And should we be gearing all up for a complete path response? Certainly, we could probably improve the chance of that with either low dose or more standard doses of radiation. I'm interested to hear what others think about that.
Thanks.
I mean, this is Jack West. I'll comment. I think that's very provocative. I think that's been a big question. A decade or more ago, I was one of many PIs of a trial that was designed to look at chemo versus chemoradiation for non-bulky N2 disease, a trial that was intergroup but closed with more investigators than patients on it, unfortunately. And it's a tough thing to study. I think what we've seen is exactly what Brendon alluded to, that you can get better responses with adding radiation. It's just a question of whether those translate to the same impact clinically post-operatively as what you achieve without the radiation. And I would also just throw in that with all of these things, as we add more and get more complex, we need to be mindful of what's doable in the rank and file community and not just at tertiary care centers. I think even Pacific is something that we, or a year of adjuvant therapy. I mentioned the attrition concerns, but that's real. These are things that we've seen real world rates of just delivering adjuvant chemotherapy. Brendon alluded to in the Alchemist trial, it was just published in JAMA Oncology, that less than half the patients who were being considered for the Alchemist trial had gotten adjuvant chemotherapy, even with a carbo regimen, let alone cis. And so I think that we need to really be mindful of what is feasible for the broad population of patients and practitioners of lung cancer in the world, and not just things that we can do in a clinical trial setting kind of selectively. Pacific also being one of those where we're just not seeing the rates of delivery of this promising platform the way that we might expect. And I think we need to really think about the barriers to implementing these broadly. How much of that is infrastructure versus the motivation or protoplasm of the patients that we see?
Yeah, I would echo that, because I think, with the data regarding use of NGS, even in stage 4 lung cancer that we saw at ASCO and others, only around 50% of patients in the community and broadly getting, testing for even the 5 molecular markers to sift through those subsets and to figure out who's going to benefit from Checkmate 816 versus Empire 10 versus Pacific versus something else incorporating radiation. I think there's just a lot of room to drop the ball, and we need to define clearly what the ball is.
Yeah, and if I can add something, so I think the problem we have, all these fantastic trials that we are mentioned here, we don't have really biomarkers that are addressing all the questions and concerns that we have, how we select the patients. And I completely agree that the next generation sequencing could be implemented. And unfortunately, we are doing not very well in stage 4. I can imagine that in early stage we will do worse in testing patients. But we need to clearly have trials including biomarkers, not only as exploratory, but trying to answer questions in biomarker, how we need to select the patients in the future, because all the target therapies that we have will be going to the scenario of a stage, early stage, and will be more and more complex for oncologists to try to select patients. If we are not even testing, that will be worse.
So maybe following from that, I'll take up on another question. This is to Narushka and Jack. So thinking about biomarkers and Checkmate 816 and Empire 10, how do we know how many doses of immunotherapy is going to be enough to really sustain that event-free survival or overall survival benefit, and to select between the approaches?
Yeah, I can start with that. I think we don't know. I think, we started with, obviously Patrick's initial sort of proof of principle study was 2 doses of Nivo alone. Now Chemo IO, Checkmate 816 is 3 doses. And we're sort of anecdotally comparing that now to 1 year of immunotherapy in Empower 10. But we don't really know what the optimum duration of therapy is. And, maybe adapting some of the biomarker approaches that Dr. Rolfo mentions is how we can sift through this and help us define what the optimum duration is. Because I think right now the choice of those timelines are largely arbitrary. Jack, I don't know what you think about that.
Well, I think exactly what you said. I think that when you see the 2 or 3 treatments is enough to get at least what seems to be comparable efficacy, we need to look at the long-term results. But we've seen at least a proof of principle from this and from people who have had very good results on immunotherapy or chemo immunotherapy and then had to stop for toxicity reasons, etc., that you don't necessarily need to have this sustained effect. I think we will get a lot more data on this, not just from these 3 trials that we've been focused on, but from a bevy of other ones that are coming around the bend that will help to clarify. We can also look at, we saw from Pacific that the outcomes for the patients who stopped after 6 or 8 months along the way are not significantly worse than the results for the patients who completed the intended 12 months. We'll have to see that for what we can find from Empower 010 and Keynote 091 Pearls as well. But I think that we'll be able to put together over time enough data to try to get a sense of whether you need a sustained exposure or not. My suspicion is no, but we'll have more data to answer that.
Excellent. Thank you, everyone, very much. I would like to just try to put a nice little bow on this wonderful, wonderful tumor board by asking each one of you, how do we approach now?
I can start by saying with difficulty and with excitement in equal measure. I think, it's great that we now have a couple of options. I think, one of the seminal changes is going to happen in our tumor boards. Obviously, historically, primary surgery has still been something, we've talked about, and implementing a neoadjuvant approach in lung cancer or thinking about that is not something that is routinely done in a lot of centers. So I think that will involve an important paradigm shift in lung cancer that hasn't been there up till now. And the second, I think, is how we incorporate genomic testing into earlier stage lung cancer, because we know that this subset of patients might behave differently. And we have to think about it now so that we can tailor this pathway for the future.
And I'll say that I think that for the next several years, we're going to have a lot more of these. I don't know about free for all, but certainly a wide range of multiple correct options. That's going to leave a lot of room for patient input on how they want to approach things. I think that's going to leave a lot of room for institutional experience and style and culture and whatever infrastructure is available without that being a wrong answer to choose one of these approaches versus other multiple right ones. And I think that what we've seen in breast cancer is that neoadjuvant moved in and created a lot of questions about whether and how we can modify the trajectory for postoperative. That's, I think, the direction of where I would like to see us go, and that's going to include incorporating liquid biopsies at multiple time points. I think that would give us potentially as much value as using PET scans in revolutionizing our understanding of how we're impacting the trajectory of a disease. And we can do that at many time points. So I would love to see in the future that we're going to move more treatment earlier, get that feedback, and then use that to shape the outcomes that follow, and see if we can use a different angle on the patients who didn't achieve a path CR and get better results for them.
Yeah, all incredible points. I think it's such an exciting time. There's so much happening. We're coming up on my dad's anniversary of passing away from lung cancer, and so I always pause to reflect upon just the startling amount of progress we've made in a short amount of time for that. And it's amazing to have so many options open. I think, like Narushka says, though, it's a paradigm shift, and neoadjuvant, sort of paying attention and getting people there on time. We're actually considering here just starting a navigation program for just neoadjuvant therapy as it works its way into more and more tumors, to really make sure that the patients get there, that they're getting timely surgery, that they're getting molecular tests, that they're getting their brain MRIs, that we're doing appropriate staging. There's just so many parts of it that now sort of we need to get surgeons to be responsible and stop and think about all these things too, and hopefully broadly adopt it. I hope that the Checkmate 816 data will convince surgeons that this is a safe strategy and that this is a strategy which should get more patients to the operating room with successful outcomes. I'll echo too what everybody said about the need for molecular testing. I'm having to move that to become reflex and to move it more upfront so that we can make these decisions real time, I think will be critical. And then finally, I echo the excitement about predictors. We're going to need liquid predictors of response to therapy. And we do have to remember that some of these patients are curable with surgery alone, and we certainly don't want to delay or knock any off of that path if we can identify ahead of time that they're not going to be a responder. So I'm excited about lots of translational work that's going on in that space to try to identify responders. And then we also need to better characterize the non-complete pathologic responders, and that's the majority of patients, right? And I think the Checkmate 816 data really shows that the survival curves for the patients with major path response are not that different from the non-responders. And so we have to unpack that a little bit and understand what that pathology means, how to select patients for additional therapy. I completely agree that it's amazing to be able to give 3 cycles and to be done with it. But there's probably some patients who are going to need more, and hopefully we can unwind that from some of the pathologic evaluation with a combination of liquid biopsies, like Christian said. And there are just so many exciting things going on that it's important that all of us are at the table together, just like this, talking about these patients in detail each time one of them comes up.
Well, it's really hard for me to add anything new here. Echo everything. Very exciting. The future is multidisciplinary even more. And it is really good to see that the precision oncology revolution that we've had for patients with stage 4 disease now finally is entering the earlier stages as well, because that's clearly on the horizon, that we will more and more tailor our treatment options to the individual disease and the individual patient. So very excited about that. And I do think from a radiation oncology perspective, even though the radiation footprint has been diminished, that there will still be a role for immune cold tumors, that there will still be a role in synergizing with immunotherapy. And I'm looking forward to that. Thank you.
And from my side, I think my colleagues were doing an excellent job in summarizing all the things. I can only add that I think we need to be a little bit more consistent in the clinical trials with the endpoints, and for example, in the case of pathological response, evaluating properly and across all the trials in the same way will be easy to take conclusions, because otherwise we are doing like they say, my colleagues, about the pears and apples, or apples and orange trials. So we need to try to make more easy to compare. It's not nice to compare trials, but at least we have an harmonization of the data. Also, the inclusion of the liquid biopsy in the clinical trials need to be following some rules. We are doing still trials with different cutoff, even if we are applying different platforms or different technologies. So this need to be also addressed. And I completely agree that the future is multidisciplinary, and actually including neoadjuvant trials and including or trying to make the colleagues in surgery more aware about this. And you say, Gil, about the Checkmate 816, that will be open more opportunities to collaborate and to convince some of the surgeons to be in favor to this approach. But still, we need to have in our institutions create a flow that the patient is not missing the time or losing period that are very important for make the flow is completely going in the patient direction and making the things in time. So the future is brilliant. We need to answer a lot of questions, but certainly we need to do in the direction that all together we are working for this early stage and increasing the outcomes and the survival of these patients.
Excellent. Thank you all very much for joining us today. The faculty, amazing discussion. Our moderators, thank you very much. And as always, as you know, OncoAlert is colleague-driven, so absolutely no support was received in the making of these tumor boards. We are very happy to do this for our colleagues, and of course, our faculty definitely always being more than generous with their time and expertise to share and take our field forward. So thank you very much to all of you. A reminder that today's tumor boards will actually be released at the end of the week, as everything has been recorded. There will be a video presentation on YouTube with slides, a podcast that will be coming out as well, along with, you can always search Twitter, hashtag OncoAlertTB, OncoAlert tumor boards, and all the tumor board tweets will be coming out, which were released in real time. So make sure to join us next time as we explore breast cancer, and we take our next case just in time for ESMO Breast. So until next time, see you on Twitter.